Hello everyone and welcome to our module on preterm and postterm infants. In this video we're going to talk about a couple of special newborn groups. The first group are infants who are born premature, which means before 37 weeks of gestation. We'll also talk about postterm babies who are born at greater than 42 weeks gestation. And then we'll finish by talking about two sort of related topics, babies that are small for gestational age or large for gestational age. These babies can be born at term, but they are just very small or very big compared to other babies born at the same gestational age. Prematurity is defined as birth before 37 weeks gestation. A normal term pregnancy is 38 weeks or longer. And sometimes premature babies are divided into those that are late preterm. These babies are born between 34 to 37 weeks gestation. They are obviously closer to term babies. And then extremely preterm babies are born before 28 weeks. And when the baby is born preterm, this is associated with many newborn complications, which we'll talk about in the next few slides. You also should know that children born prematurely can have their developmental milestones delayed during early childhood. I talk about developmental milestones in another video, but it's a collection of motor and social and cognitive abilities that the child should acquire by a certain age. When children are born prematurely, there's a delay in reaching those milestones, and so to judge the child's development, you usually correct their age. So the corrected age of the child is the actual age minus the weeks they were born premature before 40 weeks. So for example, if a child is actually 6 months of age but was born 8 weeks premature, then you need to subtract 2 months from their age, and their corrected age would be 4 months. So you would expect this child to have achieved the milestones for 4 months but not 6 months, even though the baby is 6 months old, and that's because the child was born premature. When newborns are born prematurely, there are a couple of immediate complications that you have to contend with. The first one is these babies are often cold. They have hypothermia. This happens for a couple of reasons. These babies have less white adipose tissue, which serves as insulation, so they lose heat easily. They also have less brown adipose tissue. Brown adipose tissue generates heat. It's found only in babies, and there is less of this type of adipose tissue in premature babies. They also tend to have a large surface area to weight ratio, so it's very easy for them to dissipate heat. Babies who are born premature are more likely to have hypoglycemia. All babies have some degree of hypoglycemia, but it can be worse in premature babies because their liver is underdeveloped and not able to break down glycogen and perform gluconeogenesis. Premature babies also can have hypotension. This is multifactorial. They tend to have a lower cardiac output and less vascular resistance, and so for all of these reasons they can have a very low blood pressure. In another video, I talk about neonatal hyperbilirubinemia, which can happen to all babies, including term babies, but it's worse in premature babies because they have very high unconjugated bilirubin levels. Because their liver is not able to conjugate bilirubin, the liver is underdeveloped. And so many babies who are born premature will develop newborn jaundice and need treatment for hyperbilirubinemia. And then finally, hypocalcemia is very common in premature infants. In utero, babies get calcium from their mother. So newborn hypocalcemia is common in all babies, and it usually gets better in 24 hours. But it's more common in premature babies, and so monitoring the calcium is something that's always done in babies who are premature. For the next few slides, we're going to talk about neonatal respiratory distress syndrome, which is the major cause of mortality in premature infants, and it's the major clinical problem that you have to manage when taking care of these infants. So the lungs are considered mature when there's enough surfactant present to keep the alveoli from collapsing. And this usually occurs around 35 weeks. And if a woman is pregnant and you want to know whether her baby's lungs are mature, you can do an amniocentesis and measure something called the lecithin to sphingomyelin ratio, or the LS ratio. Both lecithin and sphingomyelin are produced in equal quantities until about 35 weeks, but after 35 weeks, as the lungs mature, the amount of lecithin in the amniotic fluid begins to rise, and therefore the ratio goes up. So if you want to know if a baby's lungs are mature, you can do an amniocentesis, and if the ratio of lecithin to sphingomyelin is greater than 2, this suggests the lungs are mature. Neonatal respiratory distress syndrome occurs when babies are born prematurely and their lungs are deficient in surfactant. When there isn't enough surfactant, there's high surface tension in the alveoli and they will collapse, and this causes atelectasis. In addition, without surfactant, the lungs have poor lung compliance, which means they're very stiff, and this makes it hard for the baby to breathe as well. So this ultimately leads to hypoxemia in the newborn baby and elevated levels of CO2 from poor ventilation. And unfortunately, for babies with this condition, the lungs don't respond well to oxygen. That's because the lungs are collapsed, the alveoli are collapsed, and this causes intrapulmonary shunting, which is a mechanism of hypoxemia that doesn't improve with oxygen administration, so it can be very difficult to ventilate and oxygenate these babies. Neonatal RDS is basically a clinical diagnosis with supporting evidence from the chest x-ray. So it will be a newborn baby who was born prematurely, who has respiratory breathing trouble, and then the chest x-ray will show a diffuse ground glass appearance that makes the diagnosis. This is an example of a chest x-ray from a baby with RDS. You can see this fine white material here, that's called ground glass, and that is caused by the collapsed alveoli. So when you see this, you know the baby has collapsed alveoli, and you've made the diagnosis of neonatal RDS. The major risk factor for neonatal RDS is prematurity, but there are other risk factors. Mothers who are diabetic can have high insulin levels, and this can decrease surfactant production in the baby and increase the risk for RDS. Babies born by cesarean delivery also have a higher rate of developing RDS. That's because the baby is spared the stress response of passing through the birth canal, and this causes the baby to produce less fetal cortisol. And cortisol stimulates surfactant production. We'll talk about this in a minute. It's one of the ways you can try to prevent neonatal RDS is by administering corticosteroids. But in terms of cesarean delivery, when the baby doesn't have the fetal cortisol surge from normal vaginal delivery, there's less surfactant production in the baby. So that's a nice segue into how to prevent RDS by using steroids. So if a mother goes into labor before 37 weeks and there's going to be a preterm delivery, she is usually treated with betamethasone. It's a corticosteroid and it will stimulate surfactant production in the baby. After the baby is born, these children often require respiratory support with a ventilator, but you can also treat them with surfactant. You can administer this via an endotracheal tube directly into the lungs, and that improves outcomes in premature babies who have RDS. There are some complications of neonatal RDS you should know about. First of all, many of these babies have a patent ductus arteriosus. This is because they have hypoxia and that keeps the shunt open. In addition, many children with neonatal RDS go on to develop a lung condition in childhood called bronchopulmonary dysplasia. The lungs are still developing at the time a baby is born, and they continue to develop in the first year or so of life. And when babies are given lots of oxygen by ventilation, this causes toxicity to the lungs, and the lungs don't develop normally. There's a process called alveolarization, where the number of alveoli increase, and this does not progress normally in babies with neonatal RDS treated on ventilators. So because of this, during infancy and early childhood, these babies can have breathing difficulties, although the process of alveolarization usually eventually occurs normally, and by childhood most of these children are okay. So now that we've talked about RDS, let's talk about some of the other complications that premature babies often have. One of them can lead to blindness. It's called retinopathy of prematurity. So premature babies have underdeveloped retinal vessels. Basically, they're born with their retinal vessels not reaching as far as they normally should. So what happens is, after birth, the retinal vessels continue to grow. This is called neovascularization, but those vessels are weak and prone to hemorrhage. And if those vessels hemorrhage, they can cause retinal detachment, which leads to blindness. This is what you want to know for your boards, that retinal detachment is the cause of the blindness. If babies are given very high oxygen content by ventilation, this increases the risk. So back in the 1940s and 50s, when neonatal intensive care units first were developed, babies were treated with high levels of oxygen, and this led to an epidemic of blindness in premature babies until we learned that you need to lower the oxygen content and only give the baby as much as it absolutely needs. Using lower oxygen content makes retinopathy of prematurity very unlikely. The diagnosis is made by examining the retina, and the treatment in severe cases is similar to the treatment of wet macular degeneration. There is laser therapy to try and destroy the weak blood vessels before they develop and bleed, and there are also VEGF inhibitors which inhibit the process of neovascularization in the retina. Apnea of prematurity is a problem where premature babies will stop breathing temporarily. It's caused by underdevelopment and immaturity of the respiratory control center in the brain. So to make a diagnosis of apnea of prematurity, a baby needs to stop breathing for at least 20 seconds or have a pause in breathing associated with oxygen desaturation or bradycardia. So this is different from RDS. It's not caused by surfactant deficiency. It's just a pause in breathing that you see in premature babies. One of the ways to treat it is to apply continuous positive airway pressure through the nose. This is called nasal CPAP. It's thought that one of the triggers for apnea episodes is collapse of the nasopharynx. So by putting positive pressure into the airways, you keep it open, and the number of apneic episodes tend to decrease. You can also treat apnea prematurity by using drugs called methylxanthine. The two drugs that are used are caffeine, like you find in coffee, or theophylline, which is a drug sometimes used to treat COPD in adults. Both of these substances block adenosine receptors, and in the central nervous system, adenosine inhibits the respiratory drive. So by blocking adenosine, there's more respiratory drive. And this also decreases the frequency and severity of apneic episodes. It will, however, cause tachycardia. That's an expected effect by blocking adenosine receptors in the heart. Next, let's talk about necrotizing enterocolitis, which is a GI complication that occurs in preterm infants. Necrotizing enterocolitis refers to intestinal necrosis of the wall of the intestine, and obstruction of flow through the lumen of the bowel. It usually occurs in the terminal ileum or in the colon, and it can lead to perforation of the bowel and systemic infection and sepsis. Necrotizing enterocolitis can happen in term infants, but most cases, 90%, are in preterm infants. And it's believed to be caused by underdevelopment of the wall of the GI tract so that it can become disrupted and allow air and bacteria inside the GI tract wall, which can ultimately weaken the wall, potentially leading to perforation. Babies who receive antibiotic therapy are more likely to develop necrotizing enterocolitis. This is believed to be due to the fact that the bacteria in the colon and the gut of the baby are developing after birth, and if you disrupt that development, you increase the risk that something will happen to the wall of the GI tract. Necrotizing enterocolitis is also much more common in formula-fed babies, and it's high yield to know this for your boards. It's believed that when babies consume non-human milk, there can be an immune reaction in the walls of the GI tract, and this can predispose the baby to develop necrotizing enterocolitis. In terms of clinical features, the first sign of necrotizing enterocolitis is often feeding intolerance. The baby won't want to nurse or eat and will spit up food. Beyond this, the baby can develop abdominal distension, and when that happens, the first test that's usually ordered is an abdominal X-ray. A CT can also be done, but an X-ray is usually done first. And the finding on either X-ray or CT scan that makes the diagnosis of necrotizing enterocolitis is called pneumatosis intestinalis. This refers to gas in the bowel wall, and this is a pathognomonic finding of necrotizing enterocolitis in newborns. The treatment is mostly with supportive care. The baby needs decompression of the intestines. Antibiotics are given because bacteria from the colon can get into the bloodstream and cause sepsis, and then ultimately surgery is often required. Shown on this slide are two images of pneumatosis intestinalis. The findings in X-ray are more subtle, but notice that you can see this blackness in the wall around the bowel. That's air in the bowel wall, and that's evidence of pneumatosis intestinalis. It's easier to see by CT scan. You can see this dark ring around this loop of bowel here. That is also air in the bowel wall. GERD is gastroesophageal reflux disorder, and GERD is a common problem in adults that I talk about in detail in videos in the GI section. But GERD can also happen to babies, and it can occur in any newborn, including term newborns, but it's more common in premature babies. GERD in babies has a multifactorial mechanism, but in general, they usually have an underdeveloped lower esophageal sphincter, and this allows gastric acid to get into the esophagus. Now, in an adult, GERD causes heartburn, but a baby can't tell you that it has heartburn, so the clinical manifestations in babies are things like nonspecific irritability. The baby can just be fussy. Some babies have vomiting, and some babies eat less because of GERD and have failure to thrive. The diagnosis is usually based on a clinical suspicion, and this can be challenging because lots of babies are fussy and irritable. They don't all have GERD. In pediatrics, when you have a baby that is very fussy or difficult, pediatricians will often prescribe an acid-suppressing medicine just to see if that helps, because if the cause of the fussiness is GERD, then it may get better after the baby takes the medication. And the treatment is dietary to avoid foods that stimulate acid production. You try to position the baby by sitting the baby up after eating so that foods don't regurgitate into the esophagus. And then there are acid-suppressing medications that come in liquid form that can be given to babies. Intraventricular hemorrhage is a very serious central nervous system complication that occurs in premature babies. This refers to hemorrhage into the lateral ventricle. This is a picture of a post-mortem of a brain on a baby who died of intraventricular hemorrhage shown on the screen. When this happens, the baby will lose muscle tone and become hypotonic. The baby will stop having spontaneous movements, and there can be development of seizures or coma. The underlying cause of intraventricular hemorrhage in premature babies has to do with an area of the brain called the germinal matrix. This is a highly vascular area right near the lateral ventricles, And babies who are born prematurely have poor autoregulation of blood flow here. And what this means is that they can get a surge in blood flow, and this can lead to a rupture of a vessel, and that can bleed into the ventricle. In full-term infants, there's less vascularity of this area, and therefore intraventricular hemorrhage is rare. The diagnosis can be made by ultrasound. There are small ultrasounds that you can apply to the cranium of the baby, and you will be able to see the fluid in the ventricle. And the only real treatment for intraventricular hemorrhage is supportive care of the baby. You hope that the brain damage is minimal, and you support the baby while it recovers. And here's an example of a cranial ultrasound from a baby with intraventricular hemorrhage. The ventricles should both look like this, but on this side there's this density caused by bleeding into the ventricle. A very easy finding to identify, something that's likely to come up on your boards. All babies have an underdeveloped immune system, but it's even worse in premature babies. Their cellular immunity is impaired, they have fewer T and B cells at birth, some babies even have neutropenia, and so clinically what this means is that premature babies have a high risk of infection or sepsis, and therefore any fever in a premature baby has to be taken very seriously. So premature babies often have respiratory distress syndrome. They have to be taken care of in a NICU, on a ventilator, administered surfactant. If they survive all that and go home, there are unfortunately still some risks of long-term complications. In general, premature babies have an increased risk of mortality and morbidity, especially from SIDS. I talk about SIDS in another video, but it's the leading cause of infant mortality from 1 month to 1 year in the US. And there's an increased risk of SIDS in babies who are born preterm or babies who are born with low birth weight, which we'll talk about later. Children born prematurely also have a higher risk of neurocognitive problems later in life. They can have issues with cognition, social skills, behavioral and emotional skills, and all these things are believed to tie back to their premature birth. Beyond this, these children tend to be small overall, so they have growth impairment often throughout childhood. And as I said before, many of these children can develop bronchopulmonary dysplasia, and that can go on to cause impaired respiratory function in childhood, and sometimes it can even persist. Now let's switch gears and talk about a post-term pregnancy. This refers to delivery of the baby at 42 weeks gestation or later. Now in the United States, post-term pregnancies are uncommon, and that's because when women get close to 42 weeks, we often either induce labor or recommend an elective C-section. But when pregnancies are allowed to progress beyond 42 weeks, that's called a post-term pregnancy. And when this happens, there's an increased risk of short-term newborn complications. And most of these complications relate to macrosomia, the fact that after 42 weeks the baby is very large. One thing to know about post-term pregnancies is that even though the baby may be large, the baby can actually experience fetal growth restriction because the baby can be so big that the placenta can't support its growth. So even though these babies are large, they can have evidence of placental insufficiency and fetal malnourishment because the growth of the baby has gone beyond the ability of the placenta to provide nourishment. Another thing to know about post-term pregnancies is that there's a risk of umbilical cord compression if the baby gets very large. When this happens, the baby can suffer from asphyxia and there's a risk of neurologic damage, and this is yet another reason why pregnancies usually aren't allowed to progress beyond 42 weeks. Before that happens, either labor will be induced or a C-section will be performed. The dysmaturity syndrome is a collection of physical findings you can see in post-term babies. It's not unique to post-term babies. It occurs anytime there's intrauterine growth restriction. So like I said, when post-term babies get into the late phases of pregnancy, their growth can be restricted because the placenta can't give them enough nourishment. So you can see a dysmaturity syndrome in a post-term pregnancy. You can also see it in a baby that is small for gestational age. We'll talk about this later, but these babies can be small because they experienced intrauterine growth restriction. And like I said before, this is rarely seen in the modern era because of elective cesarean deliveries, which are usually done when pregnancies get close to 42 weeks. The cause of the dysmaturity syndrome is placental insufficiency and malnourishment of the fetus, and this leads to a characteristic appearance at birth. These babies classically have long, thin arms and legs and dry, parchment-like skin. The skin can peel off and be loose. These babies can also have long toenails and fingernails. The babies can appear very alert with a wide-eyed look, and they also tend to have a decreased or absent vernix. The vernix is a substance that sticks to the baby's skin at birth. This is a picture of what it looks like on the screen here. Babies who have the dysmaturity syndrome can have very little vernix or no vernix at all. The first stool that the baby passes is called meconium, and usually this passes after delivery, but in a post-term pregnancy, the baby can pass meconium in utero, and this can lead to the meconium aspiration syndrome. It's a syndrome of respiratory distress, and it will occur in a baby who has meconium-stained amniotic fluid at the time of birth. When there's meconium in the amniotic fluid, that means that meconium-stained fluid got into the baby's lungs, and so these babies can have tachypnea and cyanosis. And this is obviously more likely to happen if the pregnancy lasts beyond 40 weeks, because then the baby is growing to the point where he or she may pass their first stool, but they're still in utero. The treatment is supportive care. You need to maintain oxygenation and ventilation with supplemental oxygen or a ventilator if necessary, and these babies are given empiric antibiotics to protect against developing pneumonia. Now let's talk about babies that are small for gestational age, otherwise known as low birth weight babies. The definition of small for gestational age is less than 2,500 grams or 5.5 pounds in weight, or below the 10th percentile for babies at that gestational age. And this occurs in about 10% of term babies. It can also occur in preterm babies. A preterm baby can be not only preterm, but also small for the gestational age at which they were born. And low birth weight is always caused by intrauterine growth restriction. These babies had some problem getting enough nourishment from the placenta, and therefore they don't grow to the normal size of a baby at their gestational age. And when babies are born with a low birth weight, there's an increased risk of neonatal mortality and newborn complications. And many of the complications are similar to those seen for preterm babies, because these babies have the same problem in that they're underdeveloped. And the lower the birth weight of the baby, the greater the risk of complications. Shown on this slide are some of the newborn complications you can see in babies that are small for gestational age. First of all, these babies can experience asphyxia at the time of birth by vaginal delivery. That's because the placenta is chronically undernourishing the baby, and when contractions occur at birth, this can further diminish the ability of the placenta to provide nutrients to the baby, and that can lead to hypoxia. Small babies can experience all the same complications we talked about for premature babies, things like hypothermia, hypoglycemia, impaired immune function, and hypocalcemia. In addition, small babies often have polycythemia. I talk about this in another video, but babies who have intrauterine growth restriction will increase the production of red cells because they're not getting enough oxygen, so therefore at birth, these babies often have a very high hematocrit. Babies that are large for gestational age are greater than 4,000 grams or 8.8 pounds, or they're above the 90th percentile for their gestational age. And there are a couple of maternal factors that are associated with large babies. The first one is if the mother has diabetes, either gestational or pre-existing. In these cases, the blood sugar level is high, and that can lead to excessive growth in the fetus. Women who have a very high pre-pregnancy weight are more likely to have a baby that's large for gestational age, and women who gain excessive weight during pregnancy are also more likely to have a large baby. Most of the complications associated with large babies have to do with the fact that there are a lot of birth injuries that can occur both to the mother and the baby when delivering a large baby vaginally. If a large baby is delivered vaginally, some of the complications that can occur in the mother include vaginal lacerations and severe postpartum hemorrhage. There's also a high likelihood that the labor will fail to progress, meaning the mother will be unable to deliver the baby vaginally, and the delivery will have to be converted to a cesarean delivery. In terms of the baby, the complications have to do with difficult passage through the birth canal. So babies can develop a shoulder dystocia, which is where the shoulder gets caught coming out of the birth canal. Babies can have injury to the brachial plexus. They can also have fractures of the clavicle. And all these things have to do with the baby being very large as it is pushed out of the birth canal. And that concludes our module on preterm and postterm infants.